Hi and welcome to Safer Opioid Prescribing module. My name is Dr. Paul Grinzi and I'm a GP in rural Victoria and have been focused on an area of special interest of addiction medicine and drug and alcohol medicine for over 10 years. In this module we're going to be covering a number of topics. We'll have an introduction to chronic pain, then move on to identifying patients who are at risk of developing opioid related problems. We'll also talk about initiating a trial of opioids within a chronic pain setting with clear treatment goals. Part of our monitoring will include looking at 4 A's: analgesia, patient's activities, adverse effects, and also aberrant drug behaviours. And we'll finish with how to structure chronic opioid treatment for those high-risk patients you've identified. This module has 3 main learning objectives: to implement safe and effective opioid prescribing as part of a broader pain management plan, to understand the potential benefits and risks associated with opioid prescribing, and to recognise, prevent and respond to problematic opioid use. We'll start off with talking about chronic pain. Managing chronic pain is complicated. Firstly, chronic pain by definition is continuous pain, being most days of the week, for at least 3 months, that affects the function of the individual. It's actually very common. It affects up to a third of the adult population at any one time, of which about 10% is severe. So there's actually a lot more there in the population than we actually see in general practice. A lot of those patients don't present medically, but those that do are often more on the severe end of the spectrum. Now, this module is not a chronic pain module. I want to emphasise that. It's focusing on opioid prescribing within chronic pain, and chronic pain management is really a multidisciplinary approach. It involves non-pharmacological interventions, which include physical exercise, physical therapies, exercise, acupuncture, TENS, as well as psychological strategies. It includes non-opioid pharmacotherapies, which include non-steroidals, paracetamol, membrane stabilisers, antidepressants, and further classes of medications, and it also includes opioids. On this slide you'll notice that opioids is at the bottom of the list, and that's really because opioids don't have as big an effect as a lot of the public and also some of the medical profession believe. Chronic pain is an important topic, and this module incorporates a component of that, which is the opioid prescribing part, but I don't want to de-emphasise the other important parts of chronic pain management. The evidence for chronic opioid treatment within chronic pain is fairly unclear. The evidence isn't that great. We do know that the research shows us that patients who are having chronic pain respond to opioids, and that response usually is in the feature of between 20 and 30%. So they actually have a reduction in their symptomatic measures of pain, about 20 to 30%. So for example, if someone was having 10 out of 10 pain and having good effective opioid treatment, we would expect their pain subjective measures to be down to say 70% at the most. So it's not going to clear and make someone pain-free, which is quite different from what we experience with acute pain. With acute pain, we expect opioids to be able to make people pain-free. For example, someone with a fracture or with a myocardial infarction, we can actually analgese them to a point where they're pain-free. But chronic pain is quite a different beast. So opioids have an important role, but not a total role, as we'd expect if you were using the analogy of acute pain. We also know that opioids are more effective in nociceptive pain rather than neuropathic pain, and really the evidence is, well, not that great. We don't have really good evidence. The long-term studies so far have been sort of up to 12 weeks, which is not really long-term in a practical point of view. So we're really running blind to some extent. But despite this uncertain evidence, chronic opioid treatment has really increased markedly over the last decade at least. And this increase has had some really good benefits. A lot more people are being treated for pain, but unfortunately mimicking that increase has also been a lot more problematic opioid use. And this module hopefully will help you avoid some of those traps that can occur. This next slide is a bit old in terms of time frame, but the message still applies. There's a number of different opioids, and you can see how each of them have risen in popularity of prescribing over this period, the 15-year period that this slide demonstrates. The rise in each of the medications refer to both when they came on the market, but also in things like oxycodone, when marketing by the pharmaceutical companies really started to take off. Each of these trends that you can see on these slides have continued to the present day. So oxycodone now far supplants all the other opioids in terms of its regularity of prescribing. So opioids are used in chronic pain management, but we do have some concerns. And some of these concerns we can categorise into 3 different sort of categories. They are the adverse effects of the medication themselves, the effects of pain and the outcomes of pain, so often that can contribute to poor chronic pain outcomes. And also, in up to 30% of patients, they can have some aberrant drug behaviours, and we'll define those shortly. So firstly, adverse effects. To subcategorise that, we can focus on initially the intoxication effects. That's basically acute effects of having just too much opioid in your system. Most severely, that can lead to an overdose, respiratory depression and death, but also can lead to just as serious, but obviously less severe than death, things like driving accidents, falls, sedation, and those sort of acute incidences related to intoxication. Opioids also have their own side effect profiles, and some of these are very common and well known, such as constipation, drowsiness, nausea. But there are some less well commonly known ones, such as some of the neuroendocrine problems, decreased salivary output, hyperhidrosis or excessive sweating, and osteoporosis potentially as well. So there's a number of adverse effects that we need to be aware of. I wouldn't advise you necessarily to have to go through all of these potentially with every single patient, every single time you prescribe something, but just being aware that can be some unusual presentations. For example, galactorrhea can occur in a patient who's taking opioids. So if an unusual presentation does occur, just think about the opioid as a potential side effect and look up that side effect to see if it is one of those ones that have been documented. Another adverse effect that we often see in the community is not so much the problem with the opioid, but the medication it's linked with the combination analgesics. So where ibuprofen or paracetamol is linked with codeine in over-the-counter medications, it's often the ibuprofen or paracetamol dose that can be quite excessive and can cause its own adverse effects, such as renal failure, liver failure, gastric peptic ulcer disease, for example. And lastly, in terms of adverse effects, we need to consider the drug interactions. And being present in a sedative medication, opioids interact quite strongly with other medications of that same sort of effect. So benzodiazepines and alcohol are probably the two most common ones where they're co-administered and can have interactions, particularly with increasing the risk of respiratory depression and sedation. Our second main concern with chronic opioid treatment is poor chronic pain outcomes. We know that, like most chronic diseases, patients with chronic opioid treatment management do better if they are self-managing, if they're taking on some responsibility, and some of the manage it themselves and coming to see us as GPs, more for a health check and sort of advice rather than relying on us to do all the work. And chronic pain is no different. So having a passive approach from the patient's perspective is less beneficial than being quite active, and opioids unfortunately facilitate that passive approach. Taking a tablet once a day is about as active as you get with an opioid, and you're not really doing a lot of the therapy yourself. You're assuming the tablet's going to do it for you. So that passive approach is a psychological phenomenon that opioid therapy does facilitate, and it doesn't have as good an outcome as if patients are more active in their own management. Other things with pain outcomes, if the opioid is a short-acting opioid, this can actually cause more problems than something that's a longer or a slower acting. The reason for this is patients will have periods of relative intoxication and relative withdrawal quite regularly throughout every day because of the short-acting nature. And so it's reinforcing, and that's a term basically where patients will be taking the medication to minimise some of the downsides, like those early withdrawals, and really taking it quite on a periodic, regular basis to avoid the issues rather than try and help with their overall chronic pain. Another less common issue is opioid hyperalgesia. And this is not that common, but it's worth remembering if for a patient especially where they get increasing pain despite using opioids. And basically it's a sort of a reverse increasing the pain sensitivity of the patient. So the more opioid they're having, the more pain the patient's experiencing. So if you're sort of finding yourself chasing the patient's pain with increasing doses and actually getting poorer outcomes, just consider opioid hyperalgesia. It's a complicated topic, so if you do suspect this, then we would be suggesting getting some expert and peer advice about what to do with this, because it can be quite challenging to deal with directly. The third main concern with chronic opioid treatment is aberrant drug behaviours. If you look at the literature, it occurs up to 30% of the population, which isn't surprising when we look at the definition, which is taking a controlled substance medication in a manner that's not prescribed. So if you take one dose out of how it's prescribed, basically it can be defined as aberrant. Now some of these aberrant behaviours are much more serious, and some are probably a bit less serious and a bit more naive taking of the medication. So they can include things as simple as lack of understanding from either because the patient didn't understand our advice or we didn't provide it appropriately of how to actually take it. So our patient education is very important to help minimise that opportunity for aberrant behaviour. Sometimes it's external pressures where someone else is being asked to take a medication, they're in pain in the family, and that medication may be passed on because it's helped your patient and their family member needs similar pain relief, and they've provided that directly. So they're basically diverting to a family member for altruistic reasons, but still aberrant behaviour. Some patients take their opioids not for pain, but for other reasons. We sort of call this generally chemical coping or life ache. So patients who have had an argument with their spouse or having a bad day at work may take an opioid to help relieve some of that external issues that are causing, but not treating the pain directly. And remembering, opioids are prescribed for pain management and not for psychosocial issues. There's also a condition sort of known as pseudo-addiction. It looks like addiction, but it's actually not patients addicted. And we'll talk about addiction and dependence a bit later on and define that. But in terms of pseudo-addiction, it's basically where there's a few possibilities where this can go. It can look like someone's addicted to it, but it could well be that basically their pain's poorly controlled. And so they want higher doses just because the dose isn't high enough. They may have opioid-resistant pain. For example, someone with neuropathic pain, where opioids don't respond very well, their pain, they may be appearing to be addicted because they're asking for more medication or stronger medication just because it's resistant to the opioids themselves. As mentioned earlier, opioid hyperalgesia can occur, and that can sort of give us the impression that someone is addicted. And also, the actual problem, the underlying problem, may be progressive. So if they've been treated for a particular disease and it's progressing, they may want higher doses or more frequent doses or a change that can be perceived as an addiction. Another reason for aberrant drug behaviours is addiction and substance use disorder, and that basically manifested by a loss of control, and we'll define that very shortly. And lastly here, more serious would be actually deliberate diversion in terms of selling or passing on to people for their own use. And so they're all examples of aberrant drug behaviours. Aberrant drug behaviours are just markers of addiction. So they're a clue that there could be someone who's got loss of control over their drug use, but they're not addiction by themselves. So if you're noticing aberrant drug behaviours in patients, we need to sort of assess things further, and certainly looking at the dependence criteria to see whether they have addiction or not. But I wouldn't be jumping on and suggesting someone's opioid dependent just because they've got aberrant drug behaviours. But they are a good marker. And remembering these other possible causes are important, so we're not just jumping too quickly to a conclusion. It may be inappropriate. Now, if we think about red flags in the back pain literature, we have red flags that are more serious and yellow flags that are more psychosocial and warning signs. We've got similar things for opioid use. Less suggestive behaviours, we've termed yellow flags, include the following. They include medication hoarding during periods of reduced symptoms. So, for example, a patient has a good day and decides not to take their evening dose because they don't feel like they're in that much pain, and saving it just in case they have a bad day later on that week. They might just have that extra dose then. So hoarding during periods rather than taking it as prescribed, which would be usually a BD basis for most of the longer-acting sustained-release formulations. If they're using it for, as we mentioned earlier, for unapproved things, so non-pain symptoms, for sleep, for mood, for life ache, for arguments, for the psychosocial things, that would be certainly a yellow flag. If they're complaining for more medication, it's again a warning sign. And also if they're requesting a specific medication, so if you're asking it by name or by exact dose, again a yellow flag. We should consider that a risk of developing a problem, but again more of a less suggestive one than something like a red flag, which we'll cover in a short moment. Other yellow flags include openly acquiring similar medications from other prescribers, so shopping around for that medication. Sometimes that can be appropriate if they're moving around and travelling. Obviously they can't come back to you all the time, but if they're in that area, that you should be aiming to advise the patient to come to see you and you only, so that they can get their prescriptions from a regular provider. Occasional unsanctioned dose escalations are also yellow flags. So patients occasionally may increase their dose on their own bat between prescriptions and come and tell you about that. That's a warning sign. If it becomes more frequent, as we'll see in this very shortly, it's a red flag. And if they're really not adhering to other parts of their therapy, so if you ask them to take their opioid medication plus do other things such as attend their physiotherapist or the psychologist or the pain specialist or other parts, but they're really not doing those things, again, that's a less suggestive behaviour than a red flag, but certainly a warning sign that things aren't going so well. More seriously are red flags. And some of these yellow flags escalated in a few more serious things. So when they're escalating their dose in an unsanctioned format multiple times. This is a really important one, this next point, deterioration in function. So if their work or social situation is deteriorating, their marriage is falling apart or they've lost their job, those sort of functional things that are important to us, if they're deteriorating, that's certainly a red flag. If they're performing or engaging in illegal activities, I've got some examples on this slide here. Again, a red flag. If they're altering the route of administration, such as snorting or injecting as opposed to taking it orally or using it as a patch, then certainly a red flag. And if they've got multiple episodes of lost or stolen prescriptions, so red flags. Some of these are obviously illegal behaviours and much more serious. Another one that's worth considering here is they're really resistant to any change. So they've got negative outcomes, something going wrong with their therapy, and you're suggesting basically either we stop or alter their opioid therapy, and they're extremely resistant to this. That's a red flag, and it's certainly one of the features we will look at when we look at opioid dependence in terms of the criteria. If you're asking them to comply with some toxicology testing, such as a urine drug screen, and they're flatly refusing to that, again, a red flag. Most patients who are reasonable are happy with some explanation of undergoing these tests, so a flat refusal would be an area of concern. And also, if there's concurrent active abuse of alcohol or illegal drugs, it's the abuse of that, not just the use of it, but basically it's really out of control into other drugs. That's also a red flag. And the final one here is basically really a big doctor shopping network. So rather than just occasionally going to another doctor, using multiple doctors and pharmacies to obtain a prescription. If you find that information, they're also red flags. So later on this module, we'll look at red flag behaviours and also yellow flag behaviours and give you an approach if you address those. So if you see a patient with yellow flags, an approach to address how to address those. And also, if we've got a patient with red flags, what sort of things we need to do for those sort of patients. One of the things that we'd like to emphasise within this module is that when you do identify aberrant drug behaviours from a patient or from third parties, it's important to consider our role in terms of reacting therapeutically and not punishing the patient. The emphasis here really is on safety and not judging patients. And you may use words such as, look, my role here is look after your health and your safety. I'm not interested in things like whether you've done things illegally or morally, ethically. It's more about making sure you're safe and healthy. So it's really important to convey that. I often get asked, why would patients tell you this information? And it depends on how you're asking. If they're perceiving that things are private, and usually in our general practice consultations, things are pretty private. If they perceive confidentiality, and hopefully you've been able to talk to patients about this, but in this area you may even want to re-emphasise the boundaries of confidentiality. So if they're perceiving privacy and confidentiality and trust with you, then, and most patients will have chosen us, so they've often got a bit of a level of trust with their general practitioner. And then, provided they're not perceiving a negative outcome of giving you the truth, they will often give you a reasonably accurate history. The way to ask this is more about not so much the words to use, but how to use those words, how to actually convey that, so that your tone and your body language is actually much more important, I think, than the actual words you're using. Something I often describe is a tone of respective curiosity, where you're respectful for the patient and you're using terms that aren't judgmental, and you're not judging the patient, but in a really curious sort of chit-chat, conversational manner. So rather than saying, have you given this medication to any of your relatives or friends or neighbours, which is, that's, the words are fine there, but it's a very judgmental sort of a tone there, and it assumes that it's a bad behaviour to do. And so the patient may think, oh, that's not a good thing, I might give the correct answer rather than the truthful answer. You may ask in a way that say, look, some people find that they need to sort of share their medications with others that are having pain or other issues. Have you found that you've ever had the need to give it to your family or neighbours or friends for that reason? You've asked the same question but in a different context, and you sort of normalise it, saying that other people you've known have done this, and you're giving the patient permission to tell you. And by getting that information, then you can act in a therapeutic way rather than in a punishing way. So it's important just to keep that in mind, because we really don't want to get our patients to keep on our side, and we want to work with them, not cause a problem that we're going to sort of dissolve that patient-doctor relationship. When we're trying to find information about aberrant drug behaviours, as opposed to just asking the patient, it's also important to obtain collaborative data where possible. So there are other third parties that may be useful. Now, you could be cautious with asking significant others or family members in terms of consent and confidentiality. But if you've got consent to ask, or that information comes out, you can take that information on board. And sometimes it's worth just triangulating some information if you've got consent to speak to third parties. Other clinicians within the therapeutic team may involve you. Someone like the pharmacist may actually phone you and say, look, I noticed that so-and-so gave the medication as soon as they walked out of the pharmacy to someone else. And it may just provoke an opportunity to ask the patient about what's going on. The prescription shopping database, which will provide the resource at the end of this module is another source to obtain some collateral data about whether patients are sort of doctor shopping if they fulfil the criteria for that database. So one of the other ways of asking things, have you ever used your prescribed opioids for reasons other than improving function or reducing your pain? Examples could be like getting high or managing stress or escaping from your problems. That sort of question can often just get information out if you're asking it in a respectful manner and be more curious with the patient in terms of your tone. Now this is a key slide here about dependence, and this is the DSM-4 criteria. And the DSM-4 criteria is within the last 12 months, does the patient have at least 3 of the following 7 criteria? So the criteria that are listed are things like tolerance, physical dependence or withdrawal, use of larger amounts or longer than initially intended, multiple failed attempts to cut down or control their drug use, a lot of time spent finding, using or recovering from their drug use, giving up or reducing important activities, and lastly, continuing use despite knowledge of negative consequences. The first 2 there are usually fairly universal for somebody who's been taking opioids on a regular basis. Tolerance is a neuroadaptation, and most patients will have that feature. And also, as part of that, if patients stop taking their medication suddenly or reduce their dose, they'll often have a physical dependence or withdrawal syndrome. So they're fairly common things, and often you'll have those first 2 criteria almost universally in most patients who have been taking opioids for over a period of time. The following 5 criteria are more suggestive of problems of loss of control, but they're also a bit hard to interpret. So this second part of the slide here goes through some challenges when we're trying to use these criteria. And you'll notice that the bottom 2 are the most valid. This is where some patients engaging in activities or not actually given up or reduced important activities, because we know that engaging activity is expected to increase, not decline with effective pain treatment. So if things are going backwards, things aren't working, and often patients have become dependent and have lost control. The last criteria, where they've continued to use despite negative consequences, really you're not expecting harm to occur from appropriate analgesic opioid use. We need to monitor for side effects, and we should be able to mitigate against them. But if someone has big problems, either psychosocially or physically, then things should be reviewed or at least changed around. And if the patients continue to use despite these problems, that's an area of concern. And we'll have a case later on to demonstrate what that means, to demonstrate this point. This next slide was produced by a couple of different groups of psychiatrists in America. They're not the official criteria, but these criteria often give it a better impression of the loss of control that's the hallmark of addiction. So I really like the wording here. Supplements the previous slide about the DSM-4 criteria, which is a bit more clinical and a bit harder to actually put into practice. So the behavioural criteria here are really important things to assess. And the 3 things: one's impaired control over their actual use. This is like using through their scripts earlier than prepared, so they're coming in for early refills, reporting loss or theft of their medication. Withdrawals noted at follow-up appointments. So basically they're going through it. They've really lost control about that regular use that you've prescribed for them. Also in this behavioural criteria, similar to the last one of the DSM-4, continued use despite harm from opioids. So that either declining in function or they've got intoxication or oversedation, but despite those problems that can occur from those issues, continued to use. And also this preoccupation with opioids. Opioids become the focus. And as we said at the very start of this module, opioids should be only a small part, important tool, but only a small part of the overall chronic pain management treatment. And so if the opioids become a larger and larger part and patients are really preoccupied with the opioid use, it's certainly a behavioural criteria of a hallmark of loss of control. So we've talked about withdrawal when we thought we would just go through the opioid withdrawal syndrome. As you can see from the slide, the actual syndrome itself is the same in terms of the nature of the clinical features. The difference here is the shorter-acting opioids often have a more pronounced but shorter-lived opioid syndrome, as opposed to something that's a longer-acting opioid, such as methadone or buprenorphine, where they have a much more prolonged but often a flatter curve, so they may not have such a severe and acute onset. But the actual syndrome is much the same. And so the features picked up on this slide are things that you can measure from a clinical examination and also from a history point of view. So it's important to assess for these things regularly when you're seeing patients to see if they're in any level of opioid withdrawal, which may suggest some aberrant behaviour potentially. So we'll move on to how to prescribe opioids more safely. Now the bottom line here is we want to use something that's universal. So universal precautions. You may be familiar with universal precautions in terms of infection control. Say a blood spill in your practice. You don't look at the blood and go, I wonder what sort of patient it came from. Will I or won't I put on gloves? You make the assumption that the blood is potentially infectious. You put on gloves, you use bleach, you use all the appropriate infection control measures. Universally, you don't do it by a targeted measure. And same with opioid prescribing. Ideally, you use a universal approach. So given that everyone, all of us, you, me, all our patients are potentially at risk of developing problems if prescribed chronic opioids. The fact that everyone's at risk, let's treat everyone equally. We need to identify and respond to high-risk patients, but though at low risk don't mean they're immune to any problems in themselves. So part of this is really structuring opioid treatment and regular monitoring, but this is of all patients across the board. The advantages of going universal precautions is firstly, within your own practice, you'll be more consistent. So you're more likely to do this more regularly and not forget because you're doing this on a regular basis. A bigger advantage, I think, with the patients is the fact that this is depersonalising it. It's not about them, it's about you. So you're asking the patient to do certain things or asking questions. They may sort of say, well, why are you asking me this? And the answer now can be, because I ask all my patients who I'm prescribing this medication for these questions. So it's not about you, it's the fact that I do this routinely. So you're depersonalising it from them and they will have less impression that you're judging them. The next slide is a long list and it's a very busy slide and we're not expecting you to recognise everything. It would be worth, after you finish this module, just coming back to this slide and we'll provide it as a resource where these are the different features of universal precautions that have been outlined in the literature. These are all really important features, and in developing your own structure in your practice, for example, when you're developing a opioid agreement with a patient, it might be worth just going through this checklist and seeing how many of these things you're doing within your own practice. This is sort of gold standard universal precautions with chronic opioid management. So it's certainly worth a useful slide or useful resource to use as a sort of a checklist of how you're going. Okay, so now that we've talked about patients, or all patients being at potential risk of developing opioid problems, there are certain patient classifications that are at higher risk of developing these problems. And these include patients with a poorly defined pain diagnosis, so you really haven't got a good idea of exactly what's caused the pain. Those with other problems that are coexisting. They can be psychosocial or mental health problems. They can be a familial or personal history of substance use. And also can be prior personal problems of using opioids. So you may have a history of adverse events, aberrant behaviours or poor functional improvement previously. The third area that patients are usually at higher risk of developing opioid problems is where they've got poor uptake or response to other non-opioid treatments. And if you recall back to the start of this module where we talked about non-pharmacotherapy approaches such as physiotherapy, psychology, acupuncture potentially, TENS, and those sort of non-pharmacotherapy approaches, if they have been advised and patients not doing them or really having no response at all to those approaches, then it's a bit more of a concern that patients are at higher risk. And the other thing is if a patient really has unrealistic expectations, those that expect the opioids to make them pain-free are going to be at very much higher risk of developing problems because they'll be seeking a dose that makes them pain-free. And as we mentioned earlier, the realistic option there is that it's not going to do that at all. At best, it usually makes 20 to 30% improvement. So to make 100% improvement is unrealistic expectation in the majority of cases. So when we're assessing patients, we're going to use module a 4A's approach. This is sometimes referred to a 5A's or a 6A's, but the 4A's basically cover these other aspects. The extra A's have been things like accurate records. We would assume take accurate records all the time, so we're not including that by itself, but that's more of a universal approach to all of medicine. The first of the 4A's is analgesia. So patients will be often focusing on their pain, and we really want to focus on two main aspects of the pain. Now I ask the patients, what are your good days like and what are your bad days like? How's your pain when you're having a good day? How's your pain on your bad days? And this often opens up a discussion about pacing, how patients may actually try and overdo things on their good days and then have a few bad days afterwards, or they may actually pace themselves pretty well and then try and keep their function even as well as their analgesia even across good and bad days. But also may open up the discussion in terms of triggers. What created a bad day? Was it the argument with the spouse? Was it the fact that the previous day they tried to do the lawn mowing and the house painting at the same time? So that analgesia discussion can open up and give you a bit more of a clue about what's actually going on with the patient themselves. Patients are often focused on the analgesia or the pain, and so it's worth asking that first. More importantly, he's actually asking about activities, or otherwise known as function. So there are a number of different types of activities that are useful in terms of assessing. And these can be both social functions, they can be exercise, they can be forms of hobbies and recreation, and also forms of work. So asking patients about these different areas of activity and functional status is really important. So we've talked about just recently the first two A's, analgesia and activities. And to be brutally honest, the most important one here is the second, the activities. Some of my patients who can tolerate some of my sense of humour, I often say to them, not being entirely truthful, but the essence still applies. I say to them, I'd rather you be in severe pain every day of your life, be able to do the things you want to do in terms of your work, your environment, your situation, your plans and dreams, you're able to do all those things but be in pain every day, then you'll be pain-free on a couch doing nothing for the rest of your life. Now, of course, I don't want patients to be in pain every single day of their lives, but I want to emphasise that function is actually much more important in chronic pain than just pain relief itself. Chronic pain, by definition, is pain that's there almost every day for at least 3 months, and it's often much longer than that, it can be for many years. So the pain's going to be there. It's more a focus here on making sure patients can do things and be functional and have their activities attended to within their pain. Obviously, we're trying to minimise that pain, but the activities are much more important for us to assess and see how they're going. The third of the 4 A's we've got here are adverse effects. And adverse effects we've referred to earlier. They can be from intoxication, they can be the actual adverse effects of the medication, and adverse effects of the combination medications as well. So it's worth assessing for those. Don't forget the adverse effects of the effect of affect, of how it's going to affect mood. Some patients will become depressed because of the opioid. Some patients are on opioids because they're depressed and not because they're in pain. So it's worth asking about their affect as well. And also, I suppose if we go back a couple of things in terms of analgesia, how the pain relief, the amount they do get, actually affects their mood, whether they actually get improved mood because they're having a bit less pain than they were previously. So asking about affect is important as both as part of the analgesia and adverse effects. Our last of our 4 A's is the aberrant drug behaviours, and we've talked already about what these are, and I'm going to refer you back to those red and yellow flags. So aberrant drug behaviours can be just basically from a misunderstanding of how the dose should be taken. It could be taken more of a PRN basis rather than the prescribed regular daily dose, or they can lead all the way to red flags and illegal behaviours such as selling and forgery of scripts. So assessing those by asking the patient and by getting third-party information is also an important factor of the 4 A's. So just to summarise, the 4 A's, and we would suggest assessing this every time you write an opioid script. It's quite a straightforward, quick thing to do. One thing that I've done in my practice is just have a little keyboard shortcut that types my 4 A's for me, and then I can fill in the details for each patient per visit. It keeps it consistent and also allows my colleagues who might look at my patient's notes at times an idea of where things have been assessed for, where things have been assessed. Analgesia can be measured by a number of things. I talked about earlier, we're looking at good days and bad days. Whether you use pain scales, a pain diary, a numerical scale, a questionnaire, that's all up to you. Activities, one of the things I like to ask patients is what would you be able to do if the pain was well managed? So crystal ball, looking forward into the next month, if your pain was better managed, you're able to deal with more things, what things could you be able to do, and sort of look at those things themselves. Adverse effects and aberrant behaviours I think we've talked about already.